I think we should start the session, Guhan.
Okay, sir. Sure, sir. Good evening, everyone, and welcome on behalf of NeuroRehab subsection of the Indian Academy of Neurology and the chair of the NeuroRehab Pathshala, Dr. Nirmal Surya, sir. It gives me an immense pleasure in welcoming everyone here. And this is the monthly teaching series of the NeuroRehab subsection of the Indian Academy of Neurology. And every month, we keep it simple: learn, discuss, and measure. And tonight, we are on episode 2 after the initial inaugural episode. And today, we have titled it The Neglected Half, wherein we will be looking into the visual and the spatial rehabilitation. And it is now my privilege, without taking any more time, to hand over it to the chairperson of the NeuroRehab Pathshala for the evening. As I introduce the chairperson, he's a person who requires no introduction in neurorehabilitation and neurology in India, Dr. Nirmal Surya, sir. He is currently the president of Indian Federation of Neurorehabilitation, the president of Asian Oceanian Society of Neurorehabilitation, and the secretary general of the World Federation of Neurorehabilitation. With several awards to his name, it's an immense pleasure to welcome you with us here today. Thank you for being with us here, sir. Over to you, sir.
Thank you, Guhan. Uh, uh, we have got a good panel today. I think when we started this Pathshala, this is something which is going to change the way you people have been thinking. And what I gather is we never had such a systematic discussion on the topics which we have chosen so far. And today is a topic which not often been discussed. If it is discussed, it is just left that neglect is there. And I'm very glad that the faculty today is going to talk on this. Beside Guhan, there is a speech and language pathologist Mansi and neuropsychologist Porcelvi who's going to highlight on the way we should deal with these patients who otherwise are very severe disabled. So when we are talking of neglected half, we are talking of either visual or an spatial deficits which require a special sort of a rehabilitation. So let me go through in a short uh, how we are started it. It is a monthly teaching series of iron neurorehabilitation subsection, and it is a place to learn together, discuss real cases, and measure what we treat. So you learn a focused teaching talk with each episode. Then you discuss on the real illustrative cases, and then there are scales and tools to quantify deficit and track recovery so progress is seen, not assumed. Why the neglect harm? Now, each use share of the brain sees and locate. Vision and spatial attention command vast area of cortex, far more than we credit at the bedside. And after a stroke, half the world can vanish suddenly. The visual field on one side may be lost, and patients simply cannot see it, what we call as hemianopia, or be quietly ignored. The field is intact, yet one side of the space is not attended to or acted upon. This is called hemi-neglect or neglect. And these deficits are themselves neglected, under tested, under treated, the neglect half of rehabilitation. And I do not think that many clinicians do right that do the visual rehabilitation or the neglect rehabilitation. So patient can both miss the left side for entirely different reason. Now, a common, costly, and commonly missed 1 in 3 has a partial neglect and 1 in 4 has visual neglect. Stroke survivors shows partial neglect acutely and more after the right hemispheric stroke. We all know about it. And visual field defect, which is in the form of homonymous homonopia, again happen after the stroke. The visual longer admission, more falls, poor functional recovery. So this carries a very worse outcome. And most important thing is often missed among the most overlooked finding on a routine bedside exam. So approximate figures commonly cited in the stroke rehab literature reported rates vary with lesion site and the timing of assessment. Now I give you two cases. The half he cannot see is the first. A 62-year-old retired school teacher, sudden onset, bumps into the door frame on his left, leaves food on the left side of the plate, startled by the people who appear on his left. Crucially, he knows something is wrong and turn his head to compensate that when he turned he could see. And you do the imaging, you find a right piece occipital or PCA infarct. We diagnose left homonymous hemianopia, and the lesion is retrochiasmatic visual pathway. So at this point, most neurologists leave, but this is where you need to have an extra care for the rehab. There is a sensory loss, the information never arrives. In the case two, the half she does not attend to. 70-year-old woman with AF and hypertension after a large right MCA stroke. See it only from the right of her plate, grooms only the right of her face, ignores her left arm, and bumps the wheelchair on the left. Unlike the first patient, she does not know anything is wrong. That is anosognosia. Primary visual fields are intact on careful testing. So we diagnose at left partial neglect. Mechanism is right parietal temporoparietal lesion, and there is a failure to attend to and act on the left of the space. So there is an attention loss. The information arrives, contrary to hemianopia where the sensory information do not arrive but is ignored. So same complaint, different brain. The one she misses on the left from the two different brain demanding two different rehab strategy. So hemianopia, you have seen the lesion deficits. Usually patient is aware. Compensation is just by turning the head. Bedside test is confrontation field, visual field, and rehab focus is on scanning, training, field substitution. While hemi neglect, there is a right parietal temporal parietal junction, that's MCA. Deficit is attention, awareness. Often patients are unaware, that is anosognosia. Compensation is none or bedside test, line bisection, cancellation, clock drive, drawing you can pick up. Rehab focus is on cueing, prism adaptation, building awareness, mirror therapy. So telling them apart changes everything about how we rehabilitate. And today's program, you will listen about how to rehabilitate the neglected half by Guhan, and then case discussion about differentiating visual agnosia from SLP perspective. Then how do you measure the spatial neglect with the scales of inattention by OSLV, and then we'll have question and answer. So with this framework, I invite Guhan Ramamurthy to kindly start his talk. And I personally feel that if anybody has question, they should write down straight away. We would want to know what we are talking is being recepted by you. And if you have any query, you are reverting back to us. Over to you, Guan.
Thank you, sir. Thank you very much for laying the roads for us as always. And coming to the very important part where Dr. Nirmal Surya sir has left two cases for us to be answered. And these are the real cases that we face in real life where we tell them we have prescribed you medications, we amuse the patient while the nature cures the disease, because in reality, in hemianopia, most of us neurologists and clinicians, we don't take it any forward from there. And today here we have a short presentation on how to rehabilitate the neglected half. The first half is going to be hemianopia. So we all say hemianopia. The word hemianopia per se does not carry any emotion, but when we actually see how a patient actually sees the field, we feel the same heat. And this is the exact scenario. And let me reveal the deficit for you. The patient does not see to the right, and on gazing to the right, he still does not see beyond the point of fixation. And if his point of fixation is to here, then he doesn't see the whole scene. And the worst of all, he doesn't know that he is unable to see. And that's when the lack of insight that might accompany the hemianopia creates all the problem. So when does a homonymous hemianopia happen? This is the visual pathway and one that goes behind the optic chiasma. And when there is a lesion behind the optic chiasma, And this is the lateral geniculate body, the optic tract, and the optic radiations. This tract lesion posterior to the chiasma result in a homonymous hemianopia. And more posterior the lesion is, the more congruous the deficit is. The more anterior the lesion is before the lateral geniculate body, the more incongruous, or in other words, less symmetric or asymmetric the lesion is between the two eyes. So how do we actually rehabilitate it? And why does it matter on the first place? This is exactly the problem these patients actually face. The car doesn't come into their point of fixation until it crashes into them. And this is a major life-threatening situation when they actually cross the roads. And the driving, it causes the same problem, resulting in collisions not only when they drive, when they navigate through their pathways at home. The mobility becomes a problem, reading becomes a problem, and the field defect is the impairment. The disability is the life it takes away, and that is what our rehabilitation aims at. Now, this is the pathway that we all see, the routine pathway from the retina to the LGN and that to the VN, that's the visual cortex, and then to the extrastriate cortex. But there is one other pathway that we don't commonly discuss because the clinical utility of it is not as much as the primary pathway. But this pathway comes into vogue when the primary pathway, there is a lesion. Then the flow can happen only through this pathway, and that's from the retina to through the retinotectal fibers to the superior colliculus, and from there to the pulvina, to the MTV5 region, and then to the extrastriate cortex. If it's very hard to remember this pathway, we just remember that it's not the primary pathway. We bypass the primary optic pathway, that's the optic radiation in the occipital cortex. And what this pathway is concerned with is detecting motion in the periphery. So if I retrain the visual field again for repeated motions again and again in the peripheral field, then I can actually train that part of retina to detect motion, which is in fact the most important part, so that it can prevent collision when they cross the roads. So what are we looking at? Restitution, compensation, and substitution. First, let's see what restitution is about. This is based on the concept that when there is a hemianopic field here, which is the red one, and the normal one is the green one, there is a transition zone in between as detected by the perimetry, which says that there is some amount of vision that can be brought about. There is some amount of perception that is still there. And this is the concept of the visual restoration therapy, the famous Nova Vision by Kasten. Training this restitution results in an improved 5-degree border shift. So how do I train it? I ask the patient to place and fixate at the center, the crossbar, and I design where the transition zone is. Now I start the training block wherein flashes for less than 500 milliseconds while I maintain my fixation in the crossbar happens in this transition zone. And when this is done over 1 hour a day for 6 days a week, then this 5-degree of improvement will actually happen. With several sessions, what actually happens is that this area of transition zone starts to move out and the area of vision starts to increase, and that's the 5-degree for us. But what happened subsequently is that this was proven in another study by Reynard that it's actually a visual fixation. So the patient was actually moving their eyes by 5-degree, and probably that improved the 5-degree of restitution. So they say that it's not restitution, it is compensation. That's by Reynard, and that was the controversy that was surrounding the visual restoration therapy, and that has been in vogue since 2000s. And the Nova Vision software, if I'm not wrong, costs somewhere around 6,000 euros for the patency of its use. And then after the visual restoration therapy, this is the motion discrimination. What happens in the periphery of the field? We place this patch, and the motion, we ask the patient to pick up the direction of the motion, the predominant direction of motion. That is here, it is traveling to the right. And this is placed in the peripheral visual field, and the person trains over and over again. And in fact, there has to be hundreds of days of training for that retinotopic fibers to be trained to pick up the motion. And this, in fact, is the closest evidence that we have to true restitution of vision. And detecting the motion is of utmost importance. Here, these are computer-based apps, which I have shared in the group as well, which is a Meridian free-to-use app. and this has this protocol as well. So wherein there are two ways of actually doing it. One is actually ask the patient to fixate at the crossbar, and then we flash a target, and that lands in the restitution zone. That's the transition zone, thereby triggering the border zone. Now I cue it with audio along with it that produce a flash of sound, and this flash of sound can induce gaze towards the target, encouraging a saccadic movement towards that part, and this is compensation. Okay, so this, whatever we have seen right now up till now, is the restitution part. Now we are coming to the compensation part. Here is where the evidence is very, very strong. I'm unable to use the vision, so I use the movement of the eye. I train the saccade. The common question is, obviously, if a patient is not going to is not perceiving that side, he is going to move the eye to that side and is going to pick it up. Why do we train, which is natural? But the problem is they don't actually compensate naturally. They need to be trained to compensate using the saccade. And this is because many a times they lack insight as well. So how are we going to do that? Is ask them to search for targets in the hemianopic field. So here we have picked up the blind side to be right, and we start the hunt. So there is a cueing that tells that there are objects more on the right side, search for it. And here we have gamified it further, wherein we pick up the diamonds one by one, and when we have picked up everything, we cue them to look all the way to the right where there is a treasure chest. Once we complete everything else, then we go to the next level, and it's gamified. And this is for the left side where everything is repeated left and the queuing is from right to left. And the gains that result from this are very, very significant, of the order of about 30 to 45 degrees of visual field. And it means that they don't gain the visual field, but the saccades are trained to look into that direction of 45 degree. And that is truly very, very beneficial for the patient. Now, coming to the next one, we also need to train the patient, because in reading, because task specific training is of utmost importance. Just because I train them to look into that doesn't mean that the patient will be able to read subsequently. I need to train them task specific. So the one on the left is for the hemianopia, wherein the patient is unable to move beyond this side to the right. So what I do is that I move it into the visible side, and now I encourage the patient to move to the right and pick up the words before it comes to the center. This will encourage the patient to search beyond the point of fixation by compensating with the pursuit now. And one for the left hemianopia, the screen on the right side, here we tell them there is a cue that is yellow color on the left. Go all the way to the left until you see that yellow color, and then start reading it. Once they complete the sentence, search again in the next line for the yellow cue. And this is the left margin anchor, and lighting it up with a visual cue encourages them to search with a pursuit onto the left side. And this is the way reading is trained. And if none of these works, if there is no restitution, if there is no compensation, then what do we do is that we add a prism. This is the right hemianopic field. What are we going to do? Add the prism, and that is going to bring the object that is on the right side, which we were supposed to see, to this field, which is already visible to the patient. And this is by use of prisms. When I say prism, it's easy to get confused with the yoked prism, but here what we are using is a Pelly prism. These are the two prisms. One is the Pelly prism, where we place two prism stickers, one 6 millimeter above the pupil and the other 6 millimeter below the pupil. And this, what it does is that it brings the image of this up to here beyond the meridian, and therefore we are able to see this part, this part. Why don't we include the central vision here? Let me tell you that again. The other way we can reduce this portion is by diagonal Pelly prisms. And diagonal Pelly prisms further reduces this through optics, and thereby now the central point merges with the blind spot, and thereby they actually don't notice that caveat here, and they are able to, and it pretty much gives their central vision, which is of very, very helps in improving the functionality of these patients with these prisms. What happens here on the right side, what you see are the yoked prisms, where it is a whole prism by itself. What it does is that it shifts the whole field to the normal side, and in doing so, it creates a central scotoma that is known as an apical scotoma, where the patients are unable to see. There is a central path that is cut off, and so they are unable to visualize that portion, and therefore yoked prisms are useful in managing hemi-neglect, which we'll come again to when we actually see the hemi-neglect. This is the frame that we use, and this is the diplopia and visual confusion that can happen with prism use, the apical scotoma that we saw earlier. The other thing is that we are not restoring vision, we are mislocating the visual information to our benefit. So if we were to reach out, if we were to walk in that space, initially there can be an early fall risk, for which the patient has to be counseled and has to be adapted and has to be trained before they are cleared safe. And this is the utility of the prism. The latest techniques, virtual and augmented reality, based on the earlier principles that we have seen being incorporated into the virtual world, and encourage the patient to interact with the virtual world. The transcranial direct current stimulation. This is a neuromodulation where I'm going to stimulate the occipital cortex in recovering. So here it has to be combined with the visual restoration therapy or visual restitution therapy. And there are two case reports which says that with blind sight training, the border effects were facilitated by TDCS. The other neuromodulation is using a cross-frequency transcranial alternating current stimulation. And this is about 16 patient crossover trial, and it shifted borders significantly of the order of 10 to 15 degrees. Now, coming to the drug part, is there a drug that can actually help? Honestly speaking, it's not the standard of care. The evidence is not very strong, but the very low evidence is for levodopa, donepezil, and citicoline. And this is by improving the cortical plasticity that we label for the same motor recovery. And citicoline is for neuroprotectiveness, donepezil is for the cholinergic part, and the levodopa is for the dopaminergic part, all for the neuroplasticity. But citicoline can improve contrast sensitivity, but flag it all your drugs saying that its evidence is low, it's adjunctive and experimental, and it's not the standard of care. What does the evidence actually support? The strongest evidence is for the scanning and reading. And next comes the prisms, and finally the restoration, because of the confusion that was surrounding the visual restoration therapy. But all three, the problem with visual restoration therapy was the benefit that was derived with the cost that was available. So that's the reason why we have this app now, the Meridian app, which I launched. In case you have not seen, there is a clinician portal where you give the patient a code through the clinician portal, and then they set up this device, and the pixels, everything they set up, and they save the baseline, and every game that we have seen right now is going to be a part of it. And you can actually use this. It's free to use, and all the uh, training part, the visual restoration part, the compensation part that we have seen are available here. Only thing, the prisms are not computer trainable, so we don't have that yet. And this is the patient portal that we have seen. This is the clinician portal, wherein you sign in and then you provide the patient with a code, and that code here, like it is generated, they can log in using this code, and all their data will actually come to you, so you can monitor if they are actually doing it or not. Now, coming to the next portion, the neglected half, let me summarize it fast. The hemi-neglect is one thing that is really, really troublesome, because it doesn't come alone. It comes with a hemiplegia, and when it does, the patient neglects the hemiplegia as well when the neglect is severe. And it becomes very, very hard to treat the hemi-neglect, because there is no top-down phenomena in these patients for them to initiate the movements. So how does a neglect look like? So when the patient is actually feasting, they ignore the left side and ignore the left half of the plate. So if I were to, how do I rehabilitate these patients? Is by using a top-down approach where I cue them visually and auditory to look to the left. But the problem is that it is very short-lived. The neglect returns back again. Like you can see, the neglect is returning back again. The prism adaptation uses a visual input and it is a bottom up approach. If I try to use a vibration to wake the patient on the inattention side, that is a bottom up approach. And whenever I use a prism adaptation or a bottom up approach, the effects are longer than the top down approach, and thereby the effects are long lived. So these are the various tests, and these are the various types of neglect with regards to the reference frame. Due to lack of time, I might not go into the details, but these are available in the reading material that I have shared in the group. And the problem is with the hemi neglect, what the patient is supposed to see in reality, like this 6 dots, he sees these 3 and believes it to be complete, thereby resulting in poor self-care, lack of safety, poor prognosis in the motor recovery, longer hospital stays, and the inside barrier as well. So this is the patient's attempt. They try to answer or cross every star on the right field, and the bisection of the line is on the right side, queued to the right side. And what is the model for the hemi-neglect is that there is a left hemisphere, the parietal cortex, which is attending to the right, and there is a right hemisphere, which is attending to the left. This pushes it to this side and inhibits this. This cortex inhibits this. In reality, there is a balanced attention. But if there is a lesion right hemisphere, the net result is that it comes to this side and the attention is now pushed to this side or pulled to the right, resulting in a left hemi-neglect. The other version of it is that the left hemisphere attends to the right part of the space, the right hemisphere attends to the left and right part of the space, and hence when there is a left hemisphere lesion, the right hemisphere can attend to both sides, and hence the hemi-neglect is very, very less with the left-sided lesion. Whereas if there is a right-sided lesion, there is an increased prevalence of neglect. This model was created to account for the more prevalence of a left-sided hemi-neglect than a right-sided hemi-neglect. But this interhemispheric model is the one basis for neuromodulation, because neuromodulation in hemi-neglect is emerging and has a very strong evidence. So the top-down approach, which we have seen, which we will be seeing, the visual scanning one, it's a top-down approach and the effect is very fast and short-lived. Whereas for the prism adaptation, limb activation, optokinetic, it is a bottom-up, where I stimulate from the periphery. I use the other stimulatory modalities and try to kindle the patient's attention towards the left side. Or through neuromodulation, I try to rebalance the hemisphere. Let's see how we do this. Now I create a visual cue. I create a visual cue where the yellow gold line is going to blink and become bright. And I tell the patient, search for this cue line, go all the way to the left, and then give them an auditory cue and ask them to select all the dots. So there is a visual cue, there is an auditory cue, there is a numbering cue as well. So these 3 together will form the visual scanning training for the hemi-neglect. And in doing so, the patient is trained to look into the neglected site. The prism adaptation. The first time you experience prism adaptation seems magical. You wouldn't believe that you actually started exploring the left side with your own hand when the object was right in front of you. So how does that happen? Without the prism, if I see an object and I touch it here, if I add a prism, what happens? The object in reality is here, but it starts to be visualized here. I would search with this hand here, and I would realize from my sensation that the target is not there. So I move it to the left side and repeat it over and over again. This new position sensation error that is calculated by the parietal cortex, and the training is done by the cerebellar cortex. And this delta error now is trained into the motor paradigm of the hand. When I subsequently remove the prism and ask the patient to do it, he will actually go into the neglected field, because now his motor paradigms are corrected by cerebellum with the degree of prism that I have used. Usually a 10 to 15 degree prism, less than 10 to 15 degree, it doesn't work. And that's the reason why the prism adaptation literature is is very, very heterogeneous, because there are prisms which was 5-degree, and we need at least 10 to 15-degree prism to produce a meaningful improvement. And the other things are limb activation. So how do I do a limb activation? Ask the patient to move the left limb in the left hemispace with an initiation by himself. And this activation of the premotor cortex will connect with the posterior parietal cortex and improve the hemiattention. Optokinetic stimulation, very simple. This sensory visual stimulus actually moves from right to left, triggering the visual pursuit into the left space, thereby encouraging the patient to look into the left side. The third one, vestibular and neck, it's very, very powerful neck muscle vibration. 80 to 100 hertz in the posterior part of the neck, vibrating actually helps a lot in improving. Coming to RTMS, this is a model that we have discussed. The left posterior parietal cortex here is hyperactive because there is a right posterior parietal cortex lesion. So how do I do? If I have a neuromodulatory device, which is the RTMS, I use an inhibitory protocol. Now the attention is skewed to the right side. So when I deliver 1 hertz over the left posterior parietal cortex, you can see the attention is rebalancing to the center. And this RTMS is very, 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 very efficient of late with emerging evidence, because the one with the prism, it improves the measurement scores. It doesn't improve the function yet. At least whatever the data we have says that it doesn't improve the function. But RTMS is shown to improve the function, and the degree of improvement is quite a lot in the standard deviation terms compared to the prisms. And this is the galvanic vestibular stimulation. How do we do this? This is the site of placement of electrodes, anode on the left side, cathode on the right side. This is a galvanic stimulation. So intermittent galvanic current that is placed of 1 milliampere that stimulates the vestibular nucleus, and in doing so, it shifts the attention to the right side. Only the point that we need to note is that this would last as long as the galvanic stimulation is going on. So you can deliver an upper limb therapy while the galvanic stimulation is being delivered. And when the patient returns to the baseline, he doesn't return to an absolute baseline. He is improved a little better than his previous baseline. These are the typical parameters that are published online. And then the pharmacotherapy. The pharmacotherapy here is not concerned with improving the spatial attention, but overall attention. It improves the alertness of the patient, and in doing so, it activates the frontoparietal network. Here, what we are concerned is the right posterior parietal cortex, and that's through the frontoparietal attention network. These are the drugs that can help dopaminergic, we all know it, noradrenergic, cholinergic, and these are all very small data and very promising as well. The other therapies are mirror therapy, mental imagery, virtual reality, and trunk rotation, neck vibration, which you've seen earlier. This is the mirror therapy, wherein I place a mirror in the middle. I ask the patient to move the right upper limb. The left upper limb is behind the mirror, where the patient is not seeing, and he is actually seeing the right upper limb's movement into the mirror on the left side, and orients his attention to the left side. And this was published by Musk trial by Dr. Jairaj Pandian sir to be very, very beneficial for these patients. And there are several recommendations as to weak recommendation for its use, and Cochrane did not have any benefit. But nevertheless, this can add to the armamentarium of the treatment of hemi-neglect. These are all the data which is also available. The evidence for all its use is available in the reading material that has been provided in the group. You can go through that. And the final evidence summary is that scanning prism adaptation is the strongest single technique, but the functional translation is not that great. NIBS is emerging and promising RCTs, but still we need more data. Scanning training can be helpful, but its efforts are short-lived. Each has their own pros and cons. Weigh it, balance it, and use it accordingly. The eye sees it, the brain lets it go. So we reweight attention from below. The neglected half is actually neglected twice, once by the brain and once by us. With that, I thank Dr. Nirmal Surya sir for giving me this opportunity. And if there are any questions, we can take it forward.
So we have a question. Why not stimulate TCDS by TCDS, secondary visual cortex? So do you have any evidence on that?
For the evidence on secondary visual cortex, we do not have an evidence on secondary visual cortex because even the data for the primary visual cortex is very, very less. It is just 2 cases that has been reported so far, sir.
Hmm. Thank you. The people are looking for the app, and I'm sure you all join the WhatsApp group, and you will receive that app link there to use. We need to move forward, uh, and the next in line is Mansi Jagtap. Mansi is a speech and language therapist, which is she is certified in neonatal feeding, and she at the moment attached to the Bharatiya Arogya and Surya Hospital. Mansi has been the first to work on visual agnosia as early as I think 2004 or 5, when we had the first couple of patients with visual agnosia whom were coming to our Nair Hospital OPD in NeuroRehab, and Mansi was doing her postgraduate. So I asked her to work on visual agnosia, and she came out with exactly a simple formula how to do the visual agnosia rehabilitation. And to our surprise, many of the patients did improve in 3 months' time. So she has a particular distinction in dealing, probably for one of those first to deal with the visual agnosia rehabilitation in the country. And then after a couple of years, it was Guhan's teacher, Professor Lakshmi Narasimhan, who is right here now. I can see him here, who was the one who has really built up the sort of a small app to uh, deal with the visual agnosia and hemianopia. And I must say that his app was quite useful to improve the visual field. I must also say that we have tried virtual reality in many of these patients with both hemianopia as well as visual agnosia, and it has really worked. Now that you got stimulation, it might change the outcome in future. So over to you, Mansi. Before you take over, I would request Lakshmi to please highlight few points. It is always good to listen to the President of Indian Academy of Neurology, Professor
Uh,
Lakshmi Narasimhan.
Thank you. Thank you, Professor Nirmal. In fact, I was about to ask Guhan, what about the galvanic stimulation, which those days we used to do to improve hemi neglect? Using pneumatic, uh, the stimulation of the vestibular apparatus stimulation using caloric.
Yes, sir, very much, sir. And this is my favorite question, sir, because you keep asking the same question during our residency period, sir. So I have the answers ready from those times. Thank you very much for that question, sir.
Thank you.
And
A wonderful presentation, Guhan. I really enjoyed. It is always pleasure to see your students blossoming in a big way. It is indeed my real pleasure. Thank you.
Thank you. Thank you very much, sir. Thank you, sir. And with regards to the cold stimulation, I skipped it due to lack of time. But stimulating the cold on the left side actually is very, very magical in returning the hemi neglect. But it's very, very transient, and the patient gets back to the hemi neglect as soon as the effect of the cold stimulation is gone. And the patient is very distressed with that experience of the cold stimulation on the left side. And these are the reasons why that it is not very commonly practiced, though it can be helpful.
I must say that Ms. Roshan Vania, who was the first neurophysiotherapist, came to India and was in Bombay Hospital in as early as 1986-85. She was trained for Bobat techniques of the motor rehabilitation, and her technique to deal with hemi neglect was phenomenal. And in fact, she has written an article as early as in 2006 in one of our special article where she wrote about the right cerebral hemisphere treated by Bobat's technique, and patient improved significantly. So that was something some of the physiotherapists who are here, they can try the Bobat technique. Over to you, Mansi.
Um,
A very good evening to one and all. So I request the presentation to be played, please. Thank you, Nirmal Surya sir. I think he's been a source of inspiration for me right from my PG days to take up this extremely neglected topic. And he has a very big role in shaping how my career has, spanned out to me right now. Thank you very much, sir, for this opportunity. Let's get started with the case presentation.
A very good evening to one and all. At the outset, I, Dr. Mansi Jagtap, would like to thank the Indian Academy of Neurology for inviting me to present my case at this prestigious platform. Today, we're going to discuss a case of visual agnosia and how differential diagnosis is important. And I'm going to be setting my perspective as a speech language pathologist with respect to assessment and management of such cases. Mr. XYZ is a 56-year-old right-handed individual. He was proficient in Marathi language, which was his mother tongue, along with Hindi and English. His chief complaints were that he was not able to identify and name objects since 10 days. His visual acuity was not affected. He had a history of CVA with right-sided hemiparesis, and he was admitted in the hospital for 5 days for the same. When he came in for the speech and language assessment, we observed informally that his mode of communication was verbal. He was able to comprehend commands. He was expressing himself using compound and complex sentences with lot of detailing. He was able to hold conversation, which was appropriate with respect to pragmatics and extralinguistic features, which includes topic initiation, topic maintenance, and topic termination. He was able to repeat 10-word sentences adequately. However, he was unable to name objects and pictures around him. As a stroke protocol, we usually assess a patient's naming skills and other linguistic skills by doing standardized tools like the Western Aphasia Battery. More so in this patient, we did Western Aphasia Battery in Marathi. We observed that his fluency and repetition skills were adequate. The patient performed poorly with respect to naming skills, especially when it required identification and use of objects and tokens. Hence, that affected the comprehension and the naming scores in the Western Aphasia Battery. His reading and writing skills were extremely poor. He had very poorly formed handwriting, which in a way talks about poor visuospatial skills. He also had difficulty identifying letters and words, which made reading very, very difficult for him. Now, coming to specific scorings in the Western Aphasia Battery, his spontaneous speech content-wise and fluency-wise revealed word-finding problems. His comprehension for yes-no questions was adequate. However, when it came to auditory word recognition, where colors, objects, and pictures were to be found out and pointed at, that skill was affected. Comprehension for sequential commands was also affected, especially when it required picking up objects and making use of the same. His repetition skills were adequate. With respect to his naming skills, there was a variability in naming that we saw across all the sub-items. For example, object naming was poor. This is when we present the object on confrontation. With respect to word fluency, where we probably give a category to the patient and he has to name 10 to 15 items in that category, he performed adequately. Sentence completion tasks, where I would probably give an example like the grass is, and the patient has to complete it saying green. So that aspect was also adequate, and responsive speech was also adequate. As discussed before, and as we saw in our informal assessment also, his reading and writing skills were poor. So when we look into the details of the VAB interpretation, we see that this patient falls in the category of anomic aphasia. However, there was something bit different about this patient. He had adequate fluency in informal speech. He had adequate repetition. He had problems specifically in tasks which involved the pictures, cards, or objects. And he had very good responses with multimodal approach. For example, if he was not able to name a certain object, for example, a comb, if I asked him to felt the comb, he could say that yes, it is a comb. And so on and so forth for other objects like spoon or maybe a pencil. So, which meant that this problem seemed more specific to the visual modality, and his responses across other modalities, which is auditory and the tactile modality, was normal. Hence, we proceeded to do something called as the modality specific test. Now, this gives us a very different perspective of how to look at a stroke patient who may present with such variability and such atypical findings as compared to a person with aphasia. Now, here I took up 6 modality combinations. As you can see in this table, we have the modality combination. For example, it is oral, where the input modality is spoken, that is the oral modality, and the patient is expected to give a verbal response. For example, answering simple questions about himself or the surroundings. The second modality combination that we took is oral gestural. Here we had to give them specific stimuli in audition, and the person had to point or carry out a gesture. In orographical, they had to write to dictation. With respect to visual oral, they had to see and they had to either give a response in verbal format by pointing or gestural format or in a written format. Now let us look at this patient score on this. When we look at the first modality combination, he scored around a 96%. In the second subsection, where the pointing was involved, again he scored very poorly. However, when I asked him to do an action for writing a pencil, he could do that very well. The other modalities where either the input or the output modality was graphical or visual, he performed very poorly because he had very poor visual spatial perception, could be one possible explanation that we could give at that time. So apart from the modality specific test in Western aphasia battery, we took help from our neuropsychology and occupational therapy colleagues. We also carried out something that you see on the slide right now to understand the figure ground perception in the visual modality. If I present this picture to you, you can very easily say that there is a banana, there is a watch, there is a candle, and so on and so forth, even amongst a very cluttered picture over here. However, this patient failed because he was not able to make form out of any of these cluttered items. Similarly, find 5 things that appear in both pictures. So they have to basically have a little visual attention task over here, where they compare both the pictures and see which one are similar. Copying and tracing is something that is a very simple task which you can do in your clinics and can give a lot of information about a patient's visual spatial skills. Also, visual matching, matching the shapes and the colors to amongst the closed set of 4 options is another way to go about it. Coming to visual closure, where we give half of the item and the patient has to guess what object it would be. So as we look in this picture, this is a house, this is an ice cream, this is a human figure, the sun, the honeybee, and the flower. So patients with agnosias and patients with visual perceptual deficits will show these skills to be affected. Now looking at the patient performance in these skills, as we saw, the visual comprehension was affected, as we saw in the modality specific test. Visual naming also was affected. Visual tracing a simple L and a Z was affected. He was not able to copy line drawings. His visual figure ground perception was poor. Visual completion and visual matching was also affected. Now, as a speech language pathologist, along with the language skills, we also assess the other areas of speech and language. This patient had absolutely clear speech, which means that he did not have any signs of dysarthria. Also, the patient was able to perform all the gestures and all the speech tasks without any repetition on commands. There was no hesitations or transpositions in his speech. Hence, apraxia was ruled out. both for limb and for speech. He was on oral feeds and was taking adequate nutrition and hydration, and he did not have any history of aspiration pneumonia, which also rules out a swallowing deficits. His voice with respect to loudness, pitch, and quality was normal perceptually, and hence the diagnosis. Reviewing all the assessment and all the findings that we saw for a patient, our clinical impression was visual agnosia. As we can appreciate in this imaging, we can see a posterior stroke very evidently involving the occipital and the occipitoparietal lobe. For these kind of patients, a test battery approach and a multidisciplinary approach is ideal. For this patient, we had the neurologist, the speech language pathologist, the neuropsychologist, the ophthalmologist, and the occupational therapist working shoulder to shoulder with each other to find the best possible treatment plan. Each of these team members has a unique role to play. The neurologist is the first point of contact who identifies these patients and sends for further evaluations. The speech language pathologist plays a vital role with respect to ruling out a language problem and to help the patient communicate in his environment. The neuropsychologist will play a key role in carrying out the cognitive assessments and the cognitive perceptual assessments for better visual understanding. The ophthalmologist plays an important role in ruling out any issues with the visual acuity, and the occupational therapist will play a very key role with respect to helping the patient with activities of daily living. So my role as a speech language pathologist was twofold. Firstly, to modify the environment according to the best capability of the patient by suggesting high contrast labels, organizing daily objects, trying to be consistent in placing his everyday objects to avoid any confusion, to improve lighting so as to get more sharper and more clearer image, and to reduce clutter at workplace or at home. Secondly, and most importantly, we try to focus on functional communication because I think that is where the patient was feeling burst out because of his inability to identify objects and name them. So we encourage them to use multimodal approach as we saw in our assessment also. He had very good auditory and tactile input sensations. So we asked him let us take an example of one single object like the comb or the spoon. So I would ask him, if I'm presenting him with a spoon, I would ask him, try to touch and feel the object and guess what it is. So that would take part of with respect to the tactile modality. Another aspect or another way to go about it is to give a verbal cue. Coming to the same example of the spoon, I would like to have a carrier phrase like we eat with a spoon. We can also encourage recognition through sounds or context. For example, it starts with s, sp, and we use it around on a dining table when we're having dinner. So this kind of a set would help him to guess the word better. Another thing would be to use a semantic feature approach that we also use in typical anomic patients. Semantic feature analysis or semantic feature training specifically talks about naming an object by giving them attributes. For example, if we look at a mango as an object and the patient is shown the picture of a mango and he's not able to identify, my next step would be to give him attributes. For example, it is called the king of the fruits. There are a lot of varieties of the specific fruit like the Alfonso or Pyri, or we usually have these grown in India during the summers. So this kind of semantic features would give cue to the patient to identify the word being mango. So as discussed before, the take-home message for this specific case would be that do not try to fit all stroke patients in one template. Visual agnosia is not a pure language disorder and it warrants a team approach. because it has a visual perceptual and cognitive perceptual deficits. And as a team, we all can achieve more. That is what team stands for. Together, everybody achieves more. We need to understand the difference between general language disorder, that is aphasia, and modality specific cognitive perceptual deficit, which is an apnosia. This is where we really need to rely on our informal assessments and how we observe our patients at bedside. I think that itself gives us a lot of valuable information, which may get missed out when we try to get too formal with our assessments. Also, it is necessary to think out of the box. It is necessary to modify assessment as per our requirement. In such cases, especially with visual agnosias, we can use more of auditory and tactile tools for differential diagnosis, because only then we would know whether it is a general language disorder, that is aphasia, or apnosia. It is vice versa for auditory agnosia, where we can use more of visual cues for them to identify and differentially diagnose between aphasia and agnosias. So with this, I would like to end my presentation and thank each one of you for your patient listening. I hope this case presentation was an eye-opener and you would have gained some pointers to take home to your clinics out of this. Thank you very much, and thank you once again for the invitation. I'm truly honored.
Thank you, Mansi. This is a subject which is quite complicated, and I'm extremely happy that more than 225 people in today's era are online. So we understand that there is not much talk about hemi-neglect, and the way you have explained, I think it is very, very simple, and I'm sure more and more number of people are going to use this technology, both Guhan app and your simple technology in the clinic. We move to the last speaker, Dr. Porsalvi. She's a clinical neuropsychologist from Chennai, and she is a PhD in neurosciences, and she has done a lot of good work. She is in a star from India across the neuropsychology group across globe, because she has been very actively involved into the international arena and receiving the couple of early career awards and grants. So over to you, Paul Serveri, for scales. What are the simple scale the neurologists, the therapists, and others can use in their day-to-day practice?
Thank you, sir, for the very humbling introduction. So I'm aware of the time, so I'm just quickly going to the talk. So to start off, I'm going to talk about very specifically the measurement of spatial neglect. So I will be starting with a small interactive assessment of how our own attention is. So I'll be showing you two boxes. So each of these boxes will have a dot in the center. And one of them will be exactly at the center and one will be a little off from the center. In the chat, I would like you to put in whether it's left or right. So your left or right, so whatever you see in the screen, and whichever square you think has the perfectly centered dot. So as we go, so there are 10 items. It's a section of the whole test. So because we don't have the time to go over the entire test, but we'll start with 10 items, but the task gets harder as we go because the offset, like how far it is from the center, keeps decreasing. But of course, this is not what I would tell the patient when I'm assessing, but it is going to get harder, just for you to know. Which square do you think has the dot at the center? Okay.
We have right.
Okay, a lot of right.
The chat
Okay,
boxes.
perfect. And So if you notice, it's a little closer to the center now. Okay. So we have very good attention. And so this is the third one. Okay. The fourth one. The fifth one. Sixth one. Seventh one.
Everyone's spatial attention is spot on, ma'am.
Yes.
Most of the people are right,
Yes,
whether
sir.
they are right or left.
We're moving towards the end. So you can see that the dot is getting more and more towards the center.
Still right. At the left. Correct.
So now.
Left.
So I'm pretty sure everybody did pretty well. But what you did was a section of the spatial discrimination task, which is part of the TAM battery, of which I am an author. And it's a Tamil computer-assisted comprehensive cognitive test battery. So the mild neglect that we talk about when it's a right-sided neglect, and we identify that in that shrinking margin. So if you look at it, it's from 75 pixel, it goes down to 17.2. So that's the nice thing about computer-assisted assessments, because you have all of these fine details that can be captured. So subtle neglect can pass any obvious bedside task like line bisection. We will be talking about that. So we require more comprehensive assessments to detect neglect. And yes, bedside assessments, the clinical assessment is great, but we also need quantitative assessment, which has been validated for the target population in addition to the bedside screening. So there are three approaches to the measurement. So there's the bedside screening, which is typically the line bisection, star cancellation, letter cancellation task. Then we have standardized batteries like the behavioral inattention test, the visual object. We will be having those perceptual batteries as well that we will be discussing. And then there is the ecological measurement, which is direct observation of neglect. So the most commonly used scale here in both research as well as clinic is Katherine-Geiger scale, and it has but and also it has like 10 items which we will look at, and we also look at more ecological as observations. I will be covering that as well. So to begin with the basic screening test, so it has like a measure or a measured line, and we ask the patient to mark the exact center. So the true center, how much far away from the true center the patient marks is our measure for where there is a neglect. So the mark shifts towards the unaffected side. So that is contralesional neglect. It is fast, but it is insensitive. The sensitivity is low. So a normal result on this test can never rule neglect out completely. As we saw it, like we need more fine-grained sleuthing for neglect. So this is the star cancellation test, where we cross out only the small stars and not the big stars. Or there are tests in which the big stars are cancelled out where the small stars, or we might have, so there are many variations of this. So we might have different symbols and we can ask them to like cross out just the stars. The omissions are usually clustered towards one side, and that shows us the neglect. Usually on a standardized measure, there is a cutoff value below which there's evidence for neglect. So it kind of captures the visual search, and this is actually a little more sensitive than the line bisection because it includes the visual search component to it. So then this is Dr. Barbara Wilson's behavioral inattention test, the BIT. So it has two sets of complementary sets of a subtest within it. So one is the conventional subtest and one is the behavioral subtest. The conventional subtest looks more for perceptual impairment. So it has letter cancellation, the star cancellation, the usual figure copy, line bisection. And we also have a representational drawing. So like draw a chair or, like where they put lines to something or a clock or very similar to our clock drawing test that we usually do in our assessments. And the behavioral subtest has the picture scanning. So within a picture, you need to name all the different things that are there. Then there's telephone dialing. So how they look for the numbers. In this context, like even in trail making tests, we can pick up a little bit of the visual neglect, which we will be covering in a case that I will be discussing. So then there's menu reading, telling time, coin sorting, and if you can see that wash basin, like where are the objects, and then there's map navigation, card sorting. So these are the behavioral subtests which look for the ecological functioning of a person. So this component has more ecological validity, that is the generalization to the everyday functioning. So then is the CBS scale. So CBS scale has 10 items. So the items are here. So this is a clinician answered scale. So it has, does this person forget to groom on one side, or cleaning on one side of their mouth, or eats only one side of the plate, food in a plate, and forgetting one side of their body, as well as, like how they interact with the environment. Are they colliding and bumping into things or people? How are they finding their belongings within an environment? So all of this is rated. And so as you can see, the interpretation, it goes from, the scoring goes from 0 to 30. So there is 0 is no behavioral neglect, and 21 to 30 is severe behavioral neglect. So each item is scored. And there is also, this is a clinician rated version that I have on the screen. There is also self-report version within it. So we can also assess for anosognosia on it. So like we look for if there is any discrepancy between their own observations of themselves versus clinicians' observations, which as we discussed earlier, as Dr. Gohan had said, like it's very common that insight and awareness is an issue in people with hemispatial neglect. So moving on to the WASP. I personally love this battery. I wish like it will be adapted or normed and validated for our Indian population. So it has many different components to it, subtests to it. There's the shape detection in a background. So it's not a neglect specific test. It's not inattention specific test either, but it is what we use to rule out any perceptual disorders in addition to neglect. So like for example, space and object perception, we will be able to rule out any coexisting perceptual disorders, so that we will be able to pinpoint, okay, there is no confounding factors to the neglect that we detect. So this is something that again you will see in the case that I discuss. So when we compare the different scales, you can see like the line bisection and star cancellation, they're very quick, they're bedside screening. They are, star cancellation a little more sensitive than line bisection. Then there's the BIT and the WASP, which are not validated for the Indian population, but they're very good scales, which are good for looking at perceptual deficits. And then the CBS is a very ecologically valid, looking at anosognosia, real world severity, looks for ecological functioning like generalizability. The clinical rule of thumb is a normal bedside screening alone is never enough to rule out neglect in any patient. So from an Indian perspective, so I thought, I mean, because we're all here, and it'll be nice to know what we can do in Indian competent, given that those tests are not validated in the Indian population. So when we look at MOCA, there is the visuospatial items. I mean, nothing dedicated to neglect, but we will be able to pick it up if it is there. The ACE3 is another of the most commonly used cognitive screens, which has been validated across many Indian languages. It also has an illiterate version now, and it has proven high diagnostic validity. So there we have 3 components, which are like the fragmented letters, the dot counting, and the figure copy. So here also we will be able to pick up any kind of, I mean, these are screening tests, but they have these domain-specific items which we can use, which have been validated for our population. So then this is the Oxford Cognitive Screen, which is specifically developed for stroke survivors for measuring cognitive, it's a cognitive screen. So it has 2 parallel forms. And in India, currently we have a Tamil validated version, which I had worked on in 2023. Currently, we are working on with Abhishek sir and some of our NeuroRehab members in Marathi, Hindi, and Gujarati. So the nice thing about the OCS, which I like, is that it gives 2 scores. So it gives an egocentric as well as an allocentric neglect score. So if you look at these hearts, some of them have a opening on the right and some have it on the left, and some are complete hearts. So we ask them to cancel out only the complete hearts. So what we mean by the egocentric is the space asymmetry. That is, I am ignoring my left. So we compare how many complete hearts got struck out on the left half of the page versus the right of the half of the page, like how we do for star cancellation or the letter cancellation. So this captures the neglect relative to the patient's own perception of the space. So they are classically the ignoring the left or the right sided pattern that we can see the deficit. And the allocentric is when there is an object asymmetry, which is again something that we see in stroke, post-stroke. So it compares how many times the patient missed the hearts whose gap was on the left side of the heart itself versus the right side. So regardless of where that heart was on the page. So this captures neglect centered to that particular object in the heart. Where am I ignoring? So failing to notice that something is wrong on either side, like left side most commonly of a thing that you're looking at, even if it is on your right. So very thing specific. So the object asymmetry. So why does it matter? Why do I like it in the OCS? Is that these 2 forms of neglect can sometimes dissociate. Some patients can show only egocentric neglect. Some patients can show only allocentric neglect, and OCS is the only tool that I know of which quantifies this. So so in one task we get 2 neglect scores, so we don't need 2 separate tests. So then coming to the TAM battery, which I have the copyright to from 2021. So it's a comprehensive battery. So you did a part of this in the beginning of the talk. So it also includes other subtests which can detect neglect. So the quick screen module has a line bisection and a star cancellation. So all of that is on the digital mode of test administration. Then there's the clock drawing test, which we score using the Shulman's method. Then there's a spatial span. So there are 9 blocks, and then it's like digit span, but by using the position, the spatial position of the different blocks, like it lights up sequentially, and they'll have to do it sequentially as well, point it out sequentially. And then the spatial discrimination that we had. So ecological assessment should cover someone's personal space, how they interact with their immediate environment, that is their peri-personal space, and the extra personal space, so that it is more in the room around them, the environment, how do they locate things that are there around them in the room. So we need to, when we are right now, we don't have scales very specific for this, except for like maybe the BIT can pick that up because it has a behavioral component. But right now we pick this up from interview and observations. So I'm going to quickly give a case study of an atypical presentation that very recently, like I think a couple of months ago, I saw in the clinic. So Mr. C, 79 years old male, right-handed, high educated, premorbid functioning was very high. He retired as a manager of a very popular and big corporate company. And he was diagnosed with corticobasal degeneration. He was assessed in Tamil using the TAM battery. Sensory confunders here is that he was colorblind. He sees only black, white, and occasionally yellow. And he reported a hearing difficulty, but this was not assessed earlier. So when I was looking at the different clues in history, his wife mentioned that he couldn't spot objects even when they are slightly moved on the table. So, and then I had to ask, like, which direction are they usually, which was not really very reliable. But then I sort of created the situation within the assessment itself, where I was putting some of the blocks on the left and some on the right, and looking at where he was reaching at. So this was observed in the testing as well. Like if they were lightly moved, he was not able to spot them. And then there was another thing that came up where apparently in their house, the bedroom is like right next to the kitchen, and he tends to enter into the kitchen or the bedroom, like depending on, like because they're right next to each other. But most often he was entering the bedroom, meaning to go to the kitchen. So that was another thing. So then there was also the long-standing right-left confusion that he used to have, but over the last 6 months, it has worsened significantly. On neuroimaging, there was hypermetabolism in the left lateral parietal cortex, which was greater on the left than the right. So on formal testing, we had to, because of the color blindness that was reported, we had to rule out other perceptual difficulties. And then I did the spatial discrimination, the fragmented letters, both of which was impaired. Like he couldn't look at the fragmented letters, and he could see it, but he couldn't like name what letter it was. He had a very piecemeal sort of scanning there. On the trail making test, he overshot lines, and there was a right-sided neglect that was observed. Naming again, he like when there were pictures of things like, for example, there was a picture of a rhinoceros, he would say horn, and then he would move to the rest of the animal's picture. So he started from the left and struggled to integrate sometimes. So actually he failed on the, he showed impairment on the naming also, even though he didn't have any word finding difficulties. So upon other neuropsychological assessment, right-sided attentional neglect was confirmed with the impairment of global cognitive profile. He had good insight in general, but not for the neglect signs. So again, this was more right-sided and not the classic left, but it was much milder. It had to be very specifically looked for. It was embedded within a broader CBD profile. So it was a lot of cognitive impairment that was there. So here we had to use history, observation, and scores together and not just one of them. So the key takeaways from this is no single test is sufficient, especially not if it's a bedside screening tool alone, because there are milder forms of neglect, atypical forms of neglect that can be missed otherwise. And then rehabilitation point of view, like care plan point of view, those all get affected. And sensitivity varies by the task by itself. So we need to look for tests which are finer when we suspect a milder form. Function matters more. So looking for ecological clues, like asking very specific, like for example, the kitchen and bedroom was something that initially they just said like, oh, he just enters like the wrong room. And then, when we kept talking about it, the positioning of the rooms was where that clue came from. So then we have to, in history, personal, peripersonal, and extrapersonal spaces need to be measured by asking relevant questions. We need to make sure we use tools that are validated for our population. So that's where, more research, more work needs to be done. As of now, we do have some tools and some in the process of being validated. And neglect can hide in plain sight. So mild neglect and things that can be overlooked very commonly can be seen. So thank you.
Thank you, Porcelvi. One can understand the challenges dealing with such patients because one is early dementia, two is age, the attention has already been affected, the family person also had their concern. So to handle along with all these and come down to a proper clinical evaluation and testing is always going to be challenge, and that's where you really need help from neuropsychologists, and one need to have somebody good like you to refer to. So that's congratulations for Tamil version of your uh, uh, acceptance across, and that is something great. And I think it gives us another opportunity for young people to really not look at that. We look forward to the international, but certainly we start working along with our own capability and our Indian skills. So we are here to guide you guys, and you are most welcome and happy. If you have some project and you need a help, we certainly will do that. Over to you, Guhan, if there's any questions. There are a couple of questions. I think you have answered them online, but you can highlight them now, particularly the TCDS and RTMS role. I would only put one word, that these are the new technology. They still have to test the time. They are promising, but let us wait. Don't just jump on to start doing this. Let's wait for some more time to get the definite answer, have the proper studies so that we exactly know what works and what not works. If that is correct, Guhan, if you have to add into that.
Sir, absolutely, sir. All these data that we have are very small but promising. We need more data on this neuromodulation because the neglect and stroke is going to be a homogeneous population. And if we start working on it, we will have answers to it maybe 1 year down the line, sir. As of now, hemi-neglect, RTMS works well. Left posterior parietal cortex inhibitory protocol. For the hemianopia, we have evidence for TACS, transcranial alternating current stimulation, and 2 case reports with TDCS. So this is the data that we currently have.
I must also say here that early rehabilitation is the key. So if you start a patient with hemi-neglect after 6 months, I think you have lost a lot of time. So identify right on the day 2 or day 3 of the stroke and start working on that. And that is where the compensation mechanism, whatever therapy you start working.
Absolutely, sir. And that's the point we forgot to emphasize. And especially with hemianopia and hemi-neglect, 3 to 6 months, if we miss the bus, then that's going to be a very tough path ahead.
Exactly. This is why these are important points which people should know.
Yes, sir. And any words from Ramkant Yadav, sir?
Sir, I'm very thankful to Professor Dr. Nirmal Surya, sir, that in spite of some infection, he attended the meeting and very well conducted it and gave his inputs regarding the visuospatial rehabilitation. Here I want to emphasize that most of the work which has been done is on the motor rehabilitation. And surely this is a very neglected part of that visual rehabilitation. We are not taking care. So, as sir told that early diagnosis and rehabilitation of visuospatial is important. Here I want to emphasize that it is very difficult to recognize early that patient is having visuospatial neglect and all. It takes some time because patient sensorium is not good. So the scales and batteries which has been discussed may be very helpful, and we should rely on our bedside test more than other tests. And surely the regarding the treatment part, there are emerging therapies are there which we should use. But the thing is important that evidence are lacking for those, and but we should start with this and we should collect our own evidence and that should be published. So I'm again thankful to all my speakers and our chairperson, Dr. Nirmal Surya, Abhishek Srivastava, and Guhan Ramamurthy for taking lot of effort to conducting these type of Pathshalas, which are very helpful to all the neurophysicians. And the evidence is that more than 200 200 neurophysicians are attending this Pathshala. So thank you everybody for these great efforts. Thank you very much.
So do not end here. I think we come back again next month, Friday, same time, with different topic and different aspects in neurorehabilitation. So wait for our new information. Be connected into the WhatsApp group to get more and more information immediately. And we come back to you. Guhan will definitely make another session, which will be equally interesting. Over to you, Guhan. Abhishek there or he's gone?
Abhishek sir is left, sir.
Okay. So I think we close the thing.
Sir.
If there are no more question, is there anything? What rehab measure can a neuropsych use? Can you answer to Mr. Iyer?
Yes, sir. So, neuropsychological assessments right now in India, I mean, I'm assuming it's India-specific question. So right now we have some of these tests which are embedded within the cognitive screening tools. So we can pick them up from there. And also, if we look at the ICMR battery or the NIMHANS battery, there are these tests that we can use, like trail. I mean, how we interpret them also changes. So in trail making, for example, like how are they drawing their lines? How are they looking? The qualitative part of it, how are they looking for the numbers and things like that? If we can notice and make note of that, then those can be used. So.
And I think the good part is ICMR battery is free of cost and people can use that.
Yeah.
I think that's a fairly good battery and available at no cost.
Yes, sir. So shall we wind up, sir? And
yes, please.
So that brings us to the end of today's episode, and my heartfelt and sincere thanks to our chairperson, Dr. Nirmal Surya, sir, who has been leading us the way in rehabilitation, neurorehabilitation across the country and the globe, and to our faculties, Dr. Mansi Jagtap, ma'am, and Dr. A.P. Porchelvi, ma'am, for a rich and practical evening, making this neglected part bring to the center. We started with a hemi-neglect patient, a hemianopiac patient, and today knowing that it can be measured and it can be treated. And thank you for joining us today. And hold on, there is still the quiz in case any one of you are dropping out. We will just flash you the QR code. And after this ends, this is going to last for another 10 minutes.
And mind you, all the quiz, the best scorer would be felicitated during the annual conference.
And so in case you're dropping out, just hold on while we flash the QR code. And thank you for joining us today. And do watch the group as we share more updates with you. And here is the QR code of the quiz. So you can scan, and we will close the quiz by 9:10.
You can share also into the WhatsApp group, those who have left.
Yes, sir.
Wonderful.
So in case everyone has scanned it, if anyone has not scanned it, please post it in the chat group. Okay, so I'll stop share right now.
And they're asking for the presentation will be shared, whether the presentation will be shared in the group.
The YouTube video will be available on IN website. So IN YouTube channel will have this video.
Okay, sir. So we have shared, and thank you for joining us, and do watch the WhatsApp group for more updates. Until then, keep learning, keep discussing, and keep measuring. Good night. Thank you very much, sir.
Thank you. Thank you.
Good night.
Good night.
Good night, sir.